back to Blood Talks. This episode is about blood component processing and storage. Throughout this video, I will tell you where your donated blood goes and how it gets processed and prepared for patient use, including the optimal storage condition for each component type in details. This episode is a part of series Blood Donation Journey. If you have not watched the other videos, I will leave links to them in the description box down below. Without further ado, let us click that like button, subscribe, and dive deep into blood component processing and storage. Previously, we learned how whole blood is collected. Now we will follow the blood into laboratory, where CLS and technician will begin processing the whole blood unit. Most of the whole blood will be processed into blood components, and a small percentage of whole blood will be kept as whole blood. Blood component transfusion was developed and quickly gained its popularity due to its benefits. Blood component transfusion allows one whole blood donated to be processed into different components. Each component can be used safely for different patients. In short, component transfusion is when we transfuse only the component that the patient needs. Patients with low platelet count only need platelets. Since this patient does not need red blood cells, transfusing a whole blood unit is not necessary. In fact, it would be a waste of component and increase the patient's chance of develop transfusion reaction. Blood component transfusion helps limit patient exposure. This way, patients will not risk being exposed to more than what is necessary, and the patient's circulation system does not get overloaded from the extra fluid. However, the use of whole blood has its own place. The most common use of whole blood is in military and trauma situation. This is because whole blood is a preferred product in a severe traumatic hemorrhaging, or when the patient has massive blood loss. An example of injury that can cause this type of trauma is gunshot wound or car accident. Whole blood contains RBC for oxygen delivery and clotting factor that will help clot and stop the bleeding. That will bring the patient body to hemostasis faster than transfusions from two different bags of blood components. Now that we know why we are processing whole blood into components, we are ready to take a look at the process. What are the blood components? What is the function of each component? How is one donation able to save 3 lives? Each unit of whole blood can be processed into one or more of the following components. Red blood cells. Red blood cells, more commonly referred to as RBC, provide oxygen carry capacity for the patient. Each unit of RBC can increase hemoglobin by 1 gram per deciliter and hematocrit by 3%. Plasma. Plasma provides clotting factors and should not be used for volume expansion. Plasma helps with coagulation deficiency and manage patients who require replacement of multiple plasma coagulation factors. There are different types of plasma due to preparation methods. I will cover 3 types of plasma that are commonly used for transfusion. There are fresh frozen plasma, 24 hours plasma, and liquid plasma. Platelet. Platelet helps in clotting formation and stop bleeding. When there is any injury to the blood vessels, our body will try to stop the bleeding and bring itself to hemostasis. At the injury site, a complex reaction among platelet, globulin factor, soluble coagulation factors, proteins, and other factors work together. These changes allow platelet to aggregate and attach itself to the wall of the injury site to form primary hemostatic. 1 unit of platelet is expected to increase the platelet count by 5,000 to 10,000 microliter in an average adult. Cryoprecipitate, more commonly referred to as cryo. Cryo is a product that is derived from fresh frozen plasma. It contains fibrinogen, factor VIII, factor 13, globulin factor, and fibronectin. Cryo is used to control bleeding associated with fibrinogen deficiency. In an average adult, 1 bag is to raise plasma fibrinogen by approximately 50 to 75 grams per deciliter. What are the steps in blood component processing? There are 3 main steps in blood component processing: leukocyte reduction, component separation, and storage. Leukocyte reduction, also known as leukoreduce. It is the process of removing white blood cells from blood products before transfusion. It is mainly done through filtration. Leukocyte reductions of the red blood cells and other blood components is regularly done in the United States. The workflow that I will present it here is from my local blood donation center. There may be some variation, but the general process should be really similar. There are a few ways to achieve leukocyte reduction product. After storage in laboratory, if a unit did not get filtered before storage, it can be filtered at any time during its shelf life. A product can also be filtered at the bedside to help protect the patient from microaggregate and to further reduce leukocyte. Soon after collection or pre-storage, This is the most common practice for whole blood collection at the moment. Most of the blood collection bags already have a filter and a few additional bags attached to the unit. This is why we refer to blood collection bag as blood bag collection system. After the donation is completed, the units will be placed in temporary storage and taken to the laboratory. Once the unit gets to laboratory, the CLS or technician will gently mix the units while observing for clots or any other abnormality inside and outside of the blood collection bag. Then the unit will be hung and gravity will pull the whole blood through the leukocyte reduction filter into another bag. This is considered as leukocyte reduction pre-storage. After filtration, we'll have a local reduced whole blood. If there are an additive that needs to be added, then it can be done at this time. For whole blood processing, this is where it stops. The whole blood is now ready to be placed in a storage pending infectious disease results. When the unit results come back as non-reactive for all the testing, the unit is ready to be released for transfusion. Benefits of local reduced products: helps prevent the patient from forming HLA antigen, helps prevent the patient from prebio non-hemolytic transfusion reaction, helps prevent the patient from transmission of CMV. If the blood is to be processed into blood component, the process will begin right after the leukocyte reductions and the additive solution is added. How to handle whole blood before processing. Donor collection staff has to keep in mind of what product they need when handling whole blood post-collection. The end product needed is what determines how to handle whole blood before processing. If you need platelets component from whole blood, the platelet has to be separate from whole blood within 8 hours and never be cooler than 20 degrees Celsius. If we will not be making platelet from the whole blood unit, that unit should be cooled to refrigerated temperature as soon as possible. Let's start component processing with red blood cells, also known as RBC. In my opinion, it is the easiest component to make because it's just one step. Whole blood that's collected is centrifuged to separate red blood cells from platelet-rich plasma, or just simply referred to as plasma for now. RBC units contain about 150 to 230 ml of red cells. The plasma is expressed into satellite bag. Keep in mind the plasma at this point is platelet-rich plasma. It is now ready to be further processed into more components. The storage temperature of the red blood cell is at 1 to 6 degrees Celsius. This is blood fun time! The expiration date of RBC is set so that by the end of the storage time, the unit is less than 1% hemolyzed in the United States or 0.8% in European country. Currently, there is no regulation on exact number of hemoglobin, but a lower limit of 45 grams per unit for leukoreduced RBC is the standard for United States and 40 grams per unit in Europe. A preferred anticoagulants for neonate is CPDA1 and less than 10 days from collection date. Moving on to plasma. There are a few types of plasma: fresh frozen plasma, plasma frozen within 24 hours, and liquid plasmas. Fresh frozen plasma, also known as FFP. FFP can be made from either whole blood or apheresis, but in this video, we will be focusing on products that come from whole blood units. Do not worry, blood components that come from apheresis method will be included in another video. FFP should be frozen within 8 hours of whole blood collection, or 6 hours if the anticoagulant is ACD. The FFP can be kept frozen for 12 months at minus 18 degrees Celsius or colder. If stored FFP at minus 65 degrees Celsius, the FFP can be stored for longer than a year, but it will need FDA approval. Plasma can be thawed in a water bath at 30 to 37 degrees Celsius, then stored at refrigerator with label as FFP for 24 hours. The FFP can be relabeled to thaw plasma, and the units can have additional of 4 days when stored at 1 to 6 degrees Celsius. FFP contains plasma proteins that helps in clot formation. Fresh frozen plasma within 24 hours is also known as PF24. The way to make PF24 is the same as fresh frozen plasma, but instead of being frozen within 8 hours, these are frozen within 24 hours. It's easy to remember, right? It is PF24, 24 hours. Once thawed, the products can be labeled as PF24. If it is not used within the first 24 hours, it can be relabeled to thaw plasma and can be extended for another 4 days when stored at 1 to 6 degrees Celsius. We've been talking about thaw plasma. thaw plasma is a modified product for FFP or PF24. Once thaw FFP or PF24s, the product can also just be labeled as thaw plasma and give a shelf life of 5 days when healed at 1 to 6 degrees Celsius. The stable components are factor 2, fibrinogen, and ADMATS 13 level. The component that is less stable like factor 5 and factor 8 will be reduced over the storage life. Liquid plasma. Liquid plasma can be separated from whole blood at any time during storage and stored at 1 to 6 degrees Celsius for up to 5 days after the whole blood expires. Some transfusion centers may modify expiration date of liquid plasma based on literature and usage. As long as it doesn't exceed the original expiration date, it is okay. The characteristic of liquid plasma is not well understood. What we know now is that liquid plasma contains coagulation proteins and lymphocytes. Some hospitals use liquid plasma for patients undergo massive transfusion because of its abundance of coagulation proteins. It is believed to help improve chance of survival for trauma patients. Lymphocyte in liquid plasma can cause graft-versus-host disease. To decrease the chance of graft-versus-host disease, this product is often irradiated. There are two methods available for platelet preparations from whole blood collection: Buffy coat, platelet-rich plasma. Use of Buffy coat may be legal in other countries, but not in the United States. However, here is a summary of how to make platelet component from a Buffy coat. A Buffy coat is a white layer between plasma and red blood cell that is produced by hard spin of whole blood. Buffy coats are composed of leukocytes and platelets. It is not necessary to reduce the leukocyte from whole blood units before extracting platelet by Buffy coat method. It can be done afterward. A whole blood unit is centrifuged under a high forward or hard spin to separate Buffy coat. 4 to 5 units of Buffy coat are put together and then do a soft spin. The soft spin is just enough to form a soft pellet. The supplement, which is platelet-poor plasma, is removed, leaving only a very small amount to be resuspended with the pellet. That become pooled platelet concentrate. In some facilities, Buffy coats are not pulled together but processed and stored individually until the patient is needed. Once again, platelet from Buffy coats or pooled platelet is not commonly used in the United States. Another method to prepare platelet from whole blood is to prepare from platelet-rich plasma, also known as PRP. You can get platelet-rich plasma or PRP by soft spinning the whole blood units and express out the supinant. Then hard spin the supinant. The top layer is platelet-poor plasma or PPP, and the pellet is the platelet concentrate. Remove the PPP without disturbing the pellet, only leaving about 50 ml of the plasma to be resuspended with the pellet. Now you have a platelet concentrate. A Leukocyte reduction may be done at this stage or at a final processing stage depending on the policy of the facility. This platelet concentrate can be stored as individual or pooled together. Platelet is stored in agitator at room temperature, 20 to 24 degrees Celsius. Platelets survive better in vivo when stored at room temperature 20 to 24 degrees Celsius. Platelets are kept in agitator throughout its shelf life because the platelets remain metabolically active. By keeping platelets agitated, we make sure that the platelets are suspended in storage media, allowing oxygen, carbon dioxide, and lactic acid to exchange. Platelets use both glycolysis and oxidative phosphorylation to produce ATP. The byproduct of this process is lactic acid. As the lactic acid accumulates, it can cause the pH to decrease to less than 6.2, which is not suitable for transfusion. In a platelet storage bag, lactic acid is buffered by bicarbonate and exogenous buffer in an additive solution. Because it is stored at room temperature, platelet has the shortest expiration date. Due to bacterial contamination concern, platelets are usually given 5-day expiration date even though the platelet remain functional for 7 days post-collection. Cryoprecipitate antihemophilic factor is also referred to as Cryoprecipitate AHF or simply cryo. Cryo is prepared from FFP. Once FFP is frozen for 24 hours, it is then thawed out into a slush consistency, then put into a cold centrifuge. The supplement is removed and only leave about 5 to 15 ml of plasma to resuspend it with the cryo. The cryoprecipitate then can be refrozen within an hour of starting processing and stored at -18 degrees Celsius or colder for 12 months from the collection date. Once thawed out, the cryo can be stored at room temperature for 6 hours. Cryoprecipitate contains at least 80 international units of factor VIII, at least 150 mg of fibrinogen per unit, valvulant factor, factor 13, and fibronectin. Cryo is used to control bleeding due to fibrinogen deficiency, and it is also used at a therapeutic dose for valvulant disease and hemophilic A deficiency, aka factor VIII deficiency. That is it for today's episode. How was that for component processing and storage? What did you learn? Did you learn something new? Is there anything else you would like me to elaborate it more? Please let me know in the comment down below. Up next is apheresis donation and modification of blood components. Thank you for following me until the end. If you have any questions or if you want to tell me about your donation experience, please feel free to leave me a comment down below. Lastly, if you have not done so, please like, share, subscribe, and I will see you in the next episode of Blood Talk. As always, remember, your blood tells you the story of your health. Thanks for watching. Bye!